It is my pleasure to introduce our presenter, Dr. Tammy Labreche. She is an associate clinical professor at the School of Optometry and Vision Science, a graduate of the University of Waterloo. Dr. Labreche has earned a Bachelor of Science degree, a Doctor of Optometry degree, and a residency diploma in low vision and geriatrics. She joined the faculty at the school in 2004, following several years in private practice, and became a fellow of the American Academy of Optometry in 2017. Dr. Labreche provides patient care and student education predominantly in the areas of low vision in association with the university's George and Judy Wu Center for Sight Enhancement. She is the director of this CSE and the head of vision rehabilitation and enhancement services. Her scholarship interests also address areas of low vision rehabilitation and geriatric vision outreach. And with that, I'll turn it over to Dr. Labreche.
Well, thank you so much, Tina. It's so wonderful to be here, and it's so wonderful to hear that there's so much interest regarding the impact of stroke on vision. I understand that there might be a few questions that pop up. Tina forwarded me some thoughts on what you would like to hear from me, so I tried to incorporate as much as I could, but certainly we can have a discussion at the end of this presentation. All right, so learning objectives, just a quick review. We're going to discuss the types of visual consequences post-stroke that I review and consider during my clinical assessments. We'll talk about some of these consequences of stroke and where the impact occurs in the brain, and then it'll help you understand why some of the things that we're doing, or some of the things we try, are still under investigation. And then finally review the potential management of the visual deficits and some of the evidence supporting this management. Okay, so when a patient presents to us that has experienced a stroke, they may present with the following visual symptoms. So they might report difficulty with side vision, that they're bumping into things on one side or another. They may report blur. Sometimes it's intermittent. However, the blur, when it's intermittent, is more likely as a result of another neurological event and not specifically for stroke. Individuals who have experienced a stroke may experience double vision, difficulty tracking. If they're a younger individual that's experienced a stroke, less than 60, 65, they may have difficulty with focusing and issues with glare sensitivity and photophobia. Those are all kind of common visual symptoms that patients present with. But we also like to listen to other symptoms they present, such as eye strain and fatigue, headaches, slow visuomotor performance, and difficulties with balance and posture, because they're all connected, right? The eye is part of the brain. The brain has been damaged. So the main categories of visual sequelae following a stroke include alignment and movement impairment at about 68%, visual field impairment at 49%, low vision or a reduction in visual acuity and or contrast sensitivity at about 26.5%, and perceptual impairment at about 20.5%. And this is just following a stroke, so this is not after months of recovery. So let's first focus on alignment or movement impairments. The most common impairments following a stroke are an acquired strabismus or an eye turn, and motility anomalies, so how the eye moves, so difficulties with movement in some form or another. In the category of strabismus, the most common sequelae of stroke is a constant acquired exotropia. And that is what I have pictured on the left hand of the screen here, is an exotropia, and that is when one of the eye turns out. In terms of eye movement difficulties, they often demonstrate deficits of saccades. So saccades is the ability to switch our gaze from one object to another. So looking for one object and just quickly scanning over, not even scanning, just jumping over to another object. So there's a lack of coordination in that movement, a dysmetria of the saccades. That's pretty common, followed by a high prevalence of anomalies such as cranial nerve 3, 4, or 6 palsies. Cranial 3 is the most common palsy that you may see following a stroke. And that's when you'll see that a patient's eye has looks down and out. And that's a direct cause of the stroke. So they will not be able to move that eye initially, and it will lead to double vision. Sometimes there's pupil involvement or lid involvement when we have a corneal nerve 3 palsy. Visual field deficits are an impairment that often lasts a lot longer than what the strabismus or motility impairments last. So we anticipate that the strabismus may resolve, particularly if it's a strabismus that is as a result from a motility problem like a cranial nerve 3 palsy. Our visual field deficits, we do hope for some recovery from a visual field deficit, but it is not as likely, particularly if the patient has moved beyond 6 months of their recovery. A visual field deficit is different from neglect in that it is a damage to the primary visual pathway. The patient is aware of their loss. So these are the patients that are themselves saying that they're bumping into things, that they're being startled by somebody coming off to the one side. They're being startled by that pedestrian in the mall that's walking alongside them, those kind of things. So the primary visual pathway is the most common pathway that we think of when we think about eyeballs. And that is the pathway that leads right from the eye along the optic nerve, synapses in the chiasm, drops down to the LGN, and finally lands in the primary visual cortex in the occipital lobe. So we can see, or we can have a good guess of where the stroke has occurred just by what that visual field deficit looks like. So we'll actually stop just here before we go any further. I haven't actually mentioned what the primary visual pathway is called, but I'm just curious if anybody knows, because I am going to go into this a little bit more detail when we start to talk about perceptual anomalies. So for those of you that have joined us, what is the primary visual pathway called? And we can end the poll if you feel, Tina, that there are no more.
Yeah, well, people are still responding.
Okay. Don't look it up. This isn't a quiz. This isn't a test.
Okay. Yeah, they're still responding. Okay, responses coming. Okay, there's a little pause. So I'm going to end the poll now and share the results. Okay.
So it's actually called the retinal calcarine pathway. So I'm glad that I can teach you some things today. And we'll discuss a little further, like I said, when we talk about the perceptual anomalies and kind of where things deviate from primary visual pathway to more perceptual things that we consider. So retinal calcarine number 1 was the answer. All right, so I mentioned that we can tell from the pathway and where what the visual field looks like, sort of where that damage has occurred along that visual pathway. If it is an interruption just right in front or right in behind the eyes, and that's usually Not your typical area for a stroke, but it could be when we see this type of defect, sometimes it's what we call a stroke in the eye or ischemic event that has happened. We will have one eye that is left without any vision, and the other eye will still have vision. If there is any interruption that happens at the chiasm, we'll have a bitemporal hemianopsia, and that means is that both other halves of our visual field will be missing. As we move along the visual pathway, it becomes what we call more homonymous, just because of the way the fibers in the eye cross over at the chiasm. So you'll have more left-hand fibers, more left-hand viewing fibers coming from one end, and more right-hand viewing fibers that will be located on the other half of your brain. So if we have damage to right brain in the area, or let's use the example they have here, left parietal lobe brain, you have the fibers that are coming from the left side of your eye, right? But those fibers are actually seeing the right side of your field. So we'll be left with a right homonymous defect. And we have a little acronym that we like to use in optometry, and maybe even ophthalmology likes to use this, so I'm not sure. Pie in the sky. So if it's temporal, there'll be a quad in the superior area. If it's in the parietal lobe, it's in the inferior. As we progress back towards the visual cortex, we could end up here. Let me just move this little guy out of my screen here. We could end up with that complete homonymous hemianopia. Okay, so again, if we have a cut on the right hand side or the left hand side, right hand side, right occipital lobe, we will have left homonymous hemianopia. Thankfully, when it happens at the occipital cortex, you will have what we call macular sparing, and that is very, very useful for our patients in terms of their reading ability. Okay, and this is just one of the tests that I do to assess visual fields. This is a Goldman visual field. It's what we call a kinetic type visual field, so the target is moving and not flashing. And it allows for my patients post-stroke just a little bit more time to react to the stimulus. So this is a patient that has a right homonymous hemianopia here. So this side of the area they are not seeing. A homonymous hemianopia post-stroke is the most common type of visual field deficit that we do see. Reduced visual acuity and contrast sensitivity oftentimes is not directly as a result of your typical type of hemorrhagic or ischemic strokes. Certainly it is if we have individuals that have experienced those stroke to the eyes or those ocular ischemic events. But it's just, we like to put it in here because oftentimes we're dealing with individuals that are older adults and that have encountered other forms of visual impairment that may have reduced their visual acuity and contrast sensitivity. So that's something just to keep in mind in terms of rehab that's being provided for patients post-stroke. And when I mean low vision, we're talking about decreased acuity in this sense. It's not how we use the term low vision, but in the literature, that's how it's used in terms of decreased acuity and decreased contrast sensitivity. So decreased acuity is just how well they're seen on the acuity chart, and decreased contrast sensitivity as how well they see faded objects. Again, it's another type of acuity chart that we use. This is a really good indicator of how somebody is functioning in life with their visual impairment. If out of the two, we often see if it is more of a result of stroke, that it's contrast sensitivity that a patient will have difficulties with. So let's jump now to perceptual anomalies. And when we're talking about perceptual anomalies, the things that we see when we're in practice, the most common one is neglect, which I think the vast majority of you are quite familiar with and quite familiar with the management for neglect. Then we do sometimes see extinction. Extinction is kind of like a form of neglect. So there is an inattention to one side of the field, right? However, it's the inattention only occurs when the environment is busy. So if the object is presented solely on the side that they don't attend to, they will capture it. But if it's presented in a busy environment, they will focus only on the unaffected side. Some people feel that extinction is resolving neglect. The literature also has, there was one study that pointed that it could be located in a different brain region than where neglect occurs, so maybe it is a separate phenomenon. Visual midline shift syndrome is something I'll talk about in just a couple of slides, and other higher order visual perception or processing abilities are visual agnosias. So neglect, again, you're very familiar, I believe, with neglect. Just that inattention to one side. It could be personal, peripersonal, or extrapersonal. And oftentimes, as a result, are damage to the right parietal lobe. So we're often, working with somebody that has left neglect. Not always the case, but predominantly. Visual midline shift syndrome, we also call, or you can see in the literature, as an abnormal egocentric localization. It is a deviated perception of the visual midline. So instead of somebody feeling like their visual center is lined up kind of right with their nose or right along with their eyes, it's skewed on one side or the other. This syndrome was coined by a gentleman called Padula, that's his last name, and he has reported that it also creates a syndrome where there's poor eye-hand coordination, postural changes, difficulty navigating environment. So we know neglect is likely a cause of right parietal lobe damage. But what is the potential cause for this visual midline shift? And there's two theories that I have found in the literature. The one is that it's a result of neglect or maybe even a symptom of neglect. So if you are neglecting one half of your field or one half of your environment, your midline is centered within the remaining environment that you see. It's very similar. It's not exactly, but similar to the subjective straight ahead measure, which many of you may be more familiar with, where we ask somebody to point to where their center is. However, there is another theory that it could be as a result of a lack of information through the retinotactile pathway, in particular if individuals have experienced a hemiparesis. Or is it possible that you can get an altered visual midline from either theory, either pathway? So let's just have a little bit more anatomy, I guess, lesson and have a brief recap of the visual pathways. This is our eyeball and the different parts of the eyeball, and exiting the eyeball at the back of the eye is the optic nerve. The two main pathways, the two main visual pathways are the retinal-calcrine and retinotactile pathway, okay? The retinal-calcrine pathway is the one that we had mentioned before when we were talking about visual field deficits. The retinal-calcrine pathway has about 80% of the nerve fibers that leave the eye, and they travel through the primary visual pathway, synapse in the LGN, and end up in the visual cortex, which is found in the occipital lobe at the back of the brain. The gentleman that coined the VMSS term likes to call this pathway the focal pathway, and he calls it this because this is a pathway that is responsible for our detailed vision. This is the pathway that we are getting the majority of our detailed information from. So if you can imagine that you're reading a book, right, you're using a lot of that detailed, focused vision for actually seeing the words on the page. Okay, it is a slow process and it is reactive. All right, and this is that primary pathway here. Half stay on one side, half cross over, go over to the other side. Then, once it gets to the visual cortex, right, in the occipital lobe, there is a feed-forward mechanism in the dorsal and ventral pathways. If there is interruption in that dorsal pathway in the parietal lobe, that is where we're experiencing neglect. Extinction, that one article that I was talking about, says that it's maybe damage to that parietal temporal junction right in between here. Okay. So these are kind of our feed forward from that visual cortex. Our dorsal stream is our where stream. Our ventral is our what stream. But then there's also this little retinotactile pathway, okay? They kind of, instead of synapsing in the LGN, they move down right before into the midbrain. So they leave the primary visual pathway and synapse into the midbrain. So this is the remaining 20%. So 80% travel back to the occipital lobe, feed forward through the dorsal and ventral pathway. The retinotactile leaves synapses in the midbrain, and it connects, and there is a transfer of information with the superior colliculus and the pulvinar nucleus. Okay, it is our where, and Mr. Padula or Dr. Padula has referred to this as the ambient system. So what is happening here is that visual information regarding our position in space and our balance and movement is a coordinated effort through this pathway. So vision is coordinated with information from our kinesthetic, proprioceptive, our vestibular systems, so that we have our awareness of our position in space and helps with our coordination and our balance. It is a sensory motor feedback loop. Information that is received is also fed forward to higher cortical areas. This pathway allows, understandably, for spatial orientation. It is proactive. It is responsible for our flight or fight. So even before we even know that there's something there, we know what the threat is. We're already moving and thinking that we need to move our bodies, for example. It is very sensitive to movement. So, for example, allows you to know where you are in space and where you are looking before you're even able to process what you are looking at. And it allows for your release from focalization. So remember, I was talking about those saccades and that there's saccadic dysmetria that happens occasionally post-stroke, or more commonly post-stroke. Sometimes when we have a saccade, we're not actually noticing all the information in between the 2 points that we're looking at. So we're looking at one object, switching our focus to another object. We're not traveling along looking at all of the objects in between, as in a scanning movement. We release that information. So that's our retinotactile pathway that helps us release from that information that we're receiving in between and prevents us from scanning the whole way. Okay, so let's move on now and talk about a synopsis of what an optometric assessment includes. When we are assessing an individual post-stroke, we want to see somebody that has already had a structural assessment, okay? So that is predominantly your regular oculovisual assessment. And then we're going to add to that what we call a functional assessment. So not only Do we know what the structures of the eye are doing? We want to know how those structures or how that impairment has affected that individual and what we need to do to mitigate that impairment. So our structural assessment involves the routine assessment, a history, acuities, a refraction, some rudimentary tests for ocular alignment, and a good ocular health assessment. A dilated assessment is what I mean by a good ocular health assessment. A functional assessment can include any one of these tests. Predominantly for my individuals post-stroke, I'm doing a history, contrast fields, motility, and perceptual abilities. We will explore other options if I think that they're necessary. So let's move on and start discussing what some of the management options that we feel are helpful to our patients and some that still require a lot of evidence to support the work that we're doing. So things that we may consider providing, prescribing, introducing to a patient. First and foremost is a proper spectacle prescription. I'll go into detail about this a little later, but really it's the basis for a lot of even some of the tests that we conduct, right? If the patient doesn't have a proper spectacle prescription, then we can't properly assess for a strabismus or assess the motility and assess for how they're perceiving things. We might introduce filters, potentially vision therapy, maybe yoked prisms, sometimes magnification, or field enhancement in the form of often prisms. We might refer for orientation and mobility training. Okay, so let's explore all of these options and which anomaly we're addressing each one of these. So kind of the package that we're putting together for our patient, and it's not a one size fits all. The one piece of literature that I thought was really good for you to have and to review is this review that I found from Hannah and Rowe. Fiona Rowe, it does a lot of work in stroke. So her life's work is studying post-stroke care. So she did a review of the evidence-based rehab options for post-stroke visual impairment. So a lot of the information that I'm giving you is what you will find in this article, but also some of the information that I've gotten from other sources, and I'll explain when we get to those different options. Okay, so when we're talking about visual field deficits, we are going to explore compensatory rehab. So we're going to train the individual how to compensate for their field loss. So basically doing exercises so that they move their eye and head so that the impact of their visual field loss is reduced. So if they have a left visual field loss, we want them scanning and tracking into that left visual field as often as possible to be able to get the information from that side. Very, very important, particularly if this individual has a goal of returning to driving. There is substitutive therapy, which includes field enhancement prisms. And after the pool, I'll go into a little bit more detail about our field enhancement prisms. The most common and one of the ones that is most effective is called a Peli prism. It's a sectoral prism, so it's only covering one part of the lens, but it's a yoked prism. So the positioning of the lens is directed into the same direction. The base of the prism is in the area of the field loss so that it shifts information over to the non-seen area. All the therapies that we have to offer are not going to cure the visual field deficit. They're not going to make any recovery any quicker. And so this is communicated to our patients. So they understand that we're working with them to compensate for their field loss so that they can continue to do the things that they want to do regardless of the impact that that field loss has had on the individual. There was some really good research done by Pelly and his team that indicated that with the Pelly Prism, if it's worn for for a long period of time, I can't remember offhand what that period of time is, that there is a retention of about 15 degrees of visual field in the area of the prism for up to about 3 weeks. So can we call that expansion of visual field? Maybe, but it's very, very temporary. There's a lot of research going into restitutive visual field defect therapy, and this is light therapy kind of presented at the border of the field loss. The studies that have come out so far have been really inconsistent in the methodology, so they're still working on it, and maybe that might be something that might come up, but it's not something that is practiced regularly in response to visual field deficits. Okay, I think we got a poll. Oh, no, I am going to talk about the Pelly prisms first before we do our little poll. Pelly prism, so this is our Pelly prism. They're a form of a Fresnel prism. You might be familiar with Fresnel prisms. We use them for a lot of different corrections. I'll get into that a little bit more once we talk about alignment anomalies. So they're presented just up top, down below. And the idea is that the patient's looking through, but we're getting some information from the area of the field that we're missing. And the idea is that once the patient has been wearing the field, the enhance or the prism for a long enough period of time, that you will start to see two little nubbies that remain for about 3 weeks time. So that's as close as we've gotten in terms of visual field restoration, if you will, or expansion. Otherwise, we term it as enhancement, more, compensating for that field loss. Okay, next poll. Are the compensatory strategies that we use considered vision therapy? So we're talking about the compensatory strategies for visual field deficit, where we're teaching them how to scan and track their environment effectively and quickly so that they gain all the information that they need, both for mobility, but like I said, even sometimes for those patients that are wanting to pursue a goal of driving again.
Okay, just another second or so, and then I'll end the poll.
There's more certainty with this one.
Mm-hmm. Okay, there's a little pause here, so I will end and share the results.
Yes, and so we do call it vision therapy. All right, so I know that there's maybe some confusion and some hesitation with vision therapy that is provided. It has to be framed correctly, and it has to be honest, right? We're not giving back patients their visual fields when we're providing therapy. We're helping them with their scanning and tracking into their area that is missing. And then we want them to do that quickly and efficiently so that they can continue doing the activities they want to do. And I'm just going to go to that previous slide because I don't know if I actually talked about the evidence to support it. I did in the slide. But yes, so the compensatory strategies, there is some okay evidence to support it, but there is still further research required. There is a good evidence base for field enhancement prism. However, there is less compliance from patients. There's a lot of training that needs to go into for a patient to use the prisms effectively. And there's still not consistent evidence to support the restitutive therapy. Okay, so let's move on to eye alignment and movement disorders. Prism occlusion is our mainstay a lot of the times for post-stroke individuals. There is not a lot of evidence to support it, and we think that there's no evidence because it works, right? So if you cover up the eye that is that has the strabismus, the double vision goes away, the patient is happy. So, and same thing with prism. And this is not the yoked prism that I was talking about for the field enhancement. This is just prism that is placed over the one eye to correct for the alignment. So there is positioning in a different way. Again, we use a Fresnel prism, so it's kind of that sticky, ridged prism that we will use. It can be used just temporarily. The amount of the prism is reduced gradually until the strabismus is resolved. If it is resolved, sometimes there is a little bit of residual that remains. There is sometimes vision therapy that is incorporated in terms of the movement disorders that do occur. And there is really good evidence to support vision therapy for things like convergence insufficiency, which does happen at about 40% of the population post-stroke. So exercises are prescribed to help strengthen eye muscles, to overcome alignment and movement anomalies. Good vision therapy is interrupted with assessment to ensure that the patient is still improving. Okay, so after several sessions of vision therapy, there should be a check-in where we see where the patient's at, and things are revised if they're not improving, or we make a decision whether the therapy is actually effective. Okay. Reduce central vision, spectacle correction. So please don't forget about the patient's glasses when they're in hospital. They've just experienced a horrid event, and there's a lot of frenzy and flurry, and sometimes glasses are forgotten, and then there's big concern that they can't see. I have a story to share, but I'll share it towards the end about a patient. That family forgot that she needed reading glasses, and they were so concerned that she could no longer see to read. But it was actually a pretty easy one for me that I just reminded them about the reading glasses. If they have a coexisting eye condition, which has resulted in low vision, we will start looking at low vision assisted devices in the form of magnifiers or other types of magnifying devices, not necessarily a hand magnifier. There's a whole host of different devices that can help individuals with visual impairment. Our patients with low vision and post-stroke like filters, but there's not any good evidence to support it. So we tell that to patients. We let them know that, we're not sure why they work or if they work, but we let them give it a try. We lend them out to them. And a lot of our patients report that that it makes their eyes feel more comfortable. It helps objects stand out a little bit more and enhancing the contrast in that retinal image. There are some working theories behind it, but the evidence isn't there to support it. We will definitely discuss environmental modifications such as lighting as well. Okay, so now let's discuss our perceptual anomalies and what we can do for that. There's both substitutive and compensatory. There's really not a lot of evidence behind the substitutive, and that's basically patching the seeing half of the patient's attention, so that the attending half, and forcing them to use the side that they don't attend with. So if they have left neglect, patching the right side so that they're forced to look into that left area. Really one study only, so there wasn't a good analysis of that method. Compensatory, again, that's our scanning training, right? So when an individual presents with neglect, we're prompting them, we're advising them to scan into that area of field loss. There are lots of different exercises that we can prescribe or do with an individual to help promote them looking into their left area or left environment. And I'm certain that the occupational therapists and the physiotherapists that I've worked with do this as well. There is evidence to support prism adaptation. It lies both in the neuropsych literature as well as some of the optometry literature as well. This is using a prism to help shift the perception from that area of the left side in conjunction with therapy. So this isn't a prescribed pair of glasses, but it's just promoting more attention to that left side. And there was evidence to support that this help promote the attention to the neglected side for longer and longer periods of time. More research is required though. So the initial study was out in a very high impact journal, but we need to do some more to actually define it for our patients with neglect. Perceptual anomalies, visual midline shift syndrome. What optometrists are sometimes doing is prescribing something called yoked prism. So it's not the stick-on Fresnel prisms, but it is a prism again shifted in one direction. So the base is in one direction. And we're talking lower amounts of prism. And there are case studies and case reports to support it. And I've seen it myself and where it has been helpful for helping an individual with their posture and balance, but it's hit or miss, it's inconsistent. So we definitely need a lot of research in this area to understand it better and whether or not it is something that is part of the neglect compendium or if it's a separate entity to itself. And I'm pretty passionate about this area, and the people in KW are likely familiar why this is the area that I'm conducting research in. I'd like to know what the answer is. I want to know if this is something of value that I should be doing with patients and that we should be bringing to the table, or if it's something that is more a placebo effect. So look out for requests for participants for studies in this area. Okay, another big piece is working together, right? So collaborating is key. A question comes up often when to refer. All patients should have some form of visual assessment, right? After they've had a stroke. Keep in mind that not all visual assessments are the same. So if you're sending for a regular OVA, you may not get the additional consideration for some of the rehab options that could help with the field loss or the perceptual difficulties per se. So you want to ensure that the patient's getting a functional assessment, in other words. Timing, when to refer. So this is where I do want to share that story that I had of that one patient that I had seen where there was great panic because the mom could not see up close anymore, and she just had the stroke. It was just a couple of weeks out, and she was out of the, I think she was still inpatient, but she had come out to see me. And she had aphasia, and we're putting her through these tests and we're trying to do visual fields. And finally it comes out that, she just needed her reading glasses. But I remember at one point she takes the glasses that she has and she just pitches them across the room because she was done with the assessment. So definitely we need to consider the patient and where they're at and all the healing that they need to do. And sometimes they're just not ready for extra layers, right? Certainly consider some of the difficulties and some of the symptoms and signs they are exhibiting and whether or not you feel that vision could potentially be part of the problem post-stroke. As vision isn't always part of the problem post-stroke, there is a high prevalence, but it's not always there. Another time to consider referral for a functional assessment is, consider the status of the rehabilitation. Is it stagnant? Is maybe there another piece that needs to be brought to the table? So collaboration. So we can collaborate by identifying the individuals that do have visual impairment, identifying and supporting each other through the therapeutic activities that we're conducting on both ends, right? Because sometimes it's a little bit too much. If I know that you're doing something, I'm not going to repeat it. You see that patient far more than I do. And communication back and forth is certainly key. All right. That is my very, very quick synopsis of the impact of stroke on vision. So there is an evaluation form that you are free to fill out, and then we will address some of the questions that you might have.
Yes, thank you very much. We do have a question that came up from Orla, and this goes back to your pie in the sky. She'd like you to repeat the acronym and perhaps explain it.
So pie in the sky. So pie, parietal inferior, temporal superior. So this is for our quad defect. So just that little pie-shaped defect that we have. If it's in the parietal lobe, it's more likely to be inferior quad defect. If it is a temporal lobe, more likely to be a superior quad defect.
Okay. Okay, thank you. And Laura, Orla, if you have a follow-up question, please feel free to okay, she said thank you. Okay, and so there is the Q&A, or you can continue to put questions in the chat. If you would like to unmute, you can put your hand up, and you can also ask a question verbally if that's a preference. Okay, Susan has a question. Can a local optometrist provide vision therapy post-stroke?
It is something that not all optometrists do provide, but they usually know the providers in their area. So we can't claim specialty in optometry, but there are definitely people that have taken some extra education in particular areas, and so they will provide it for their patients.
Okay, thank you. Claire has a question. So in general, should you wait until a few weeks out from their stroke to recommend that they make an optometrist appointment?
It really depends on the concern and impact, right? And where the patient is at and the whole entirety impact of the stroke. Sometimes it's just vision, right? It's just vision. Other therapy is not as needed. And then those people I would bring in early on post-stroke, right? But if they have a lot on their plate, then I would definitely wait out a few weeks. And can I just clarify the last question? All optometrists can provide vision therapy, but not all optometrists provide in-office vision therapy, okay? So they can prescribe some exercises for you to take home, and it just may not be as many that could potentially be provided, and it may not be in office. Does that make sense?
Well, Susan did write a thank you.
Okay.
And if there's a follow-up question, it can always be put in
Okay.
the chat. Okay, and there's another question here. Could you speak further to patching occlusion for the diplopia?
Yeah.
i.e. where to patch, when, how to progress
Okay.
binasal occlusion?
Oh, okay. So patching is something that is done in response to somebody that has double vision. And the double vision is coming from them trying to work both of their eyes together when one of their eyes is not cooperating. These individuals do need to see an optometrist early on in their progress. But just, yeah, so they'll notice both eyes open, double vision, one eye closed, no vision, no double vision. So it alleviates a lot of stress on the patient not to view that double vision. But we really do need to understand the cause of the double vision, the type of, palsy or impairment, and then monitor the progression.
Okay. Thank you. Marie-José has a question. Does OHIP cover vision therapy and the exam?
No. So it will cover regular eye exam. So it'll cover your basic acuities, refraction, some review of your eye muscles. If the patient has like a cranial nerve palsy, it will cover that, as well as to follow-up visits if we're introducing some prism to mitigate the diplopia for a palsy, but it does not cover for any vision therapy.
Thank you. Alexandra, are vision therapies effective for patients with central nystagmus or end gaze nystagmus post-stroke?
So endpoint nystagmus, I haven't seen a lot of evidence to support that, but that's not an area that I have encountered that often. I'd have to look into that. So the answer is I don't know.
Okay, thank you. Melissa has a question. Also, thanks for the great info. And when would you refer to ophthalmologist versus neuro-ophthalmologist?
Yeah, so if you have, so your neuro-ophthalmologist is the person that understands neurology the best, right? So they're ideal for following up with a person, but they might see them and then feel that your general ophthalmologist can continue with management. Your ophthalmologist is the individual that is going to introduce different surgeries or potentially some medical intervention. They don't usually provide the rehab part of things.
Okay. Bridget has a question. When is an appropriate time after stroke to refer patients to the CNIB?
So I would refer to an optometrist before referring to the CNIB, because the CNIB needs some information to be able to do their work effectively. So they need to have what the visual parameters are.
Okay. And we have a question in the Q&A. Is there evidence to support the use of prisms for Pusher's syndrome?
Not strong evidence. There's case reports. So this is another reason why I'd like to look into this research. Just it's one of those kind of outside, those little anomalies that we'd really like to find something that helps. There has been some case studies that has worked with prisms that has helped, but it's not strong evidence.
Okay. And we have another question. When patching to reduce diplopia, there's often an impact on depth perception. Is there therapy suggested to improve that, as it also impacts function and safety?
So when your patient is seeing double, they don't have any depth perception. So it's an either or, and the vision therapy can be an adjunct to potentially move that eye muscle along to help support it in regaining some function. I think we need some stronger evidence to support whether or not it would resolve independently or if vision therapy helps speed it up. I have seen some cases where it helps, but there isn't a lot of evidence, like high quality research, if you will. And I think it's more a conversation of what you have with your patients when you're introducing things that don't have a lot of evidence to support them, right? To let them know what we're doing, because this is how we sometimes learn, right?
Okay. Thank you. If anyone has any other questions, we just have a few more minutes. If you'd like to put it in the chat or in the Q&A, or again, as I said, you're welcome to raise your hand. Okay, well, we do have another one from Alex. How cognitively intact do patients need to be for a thorough assessment? We have a patient who has poor ability to see environment, but with vascular dementia and very poor cognition. It is difficult to assess what is wrong.
Yeah. So vascular dementia, post-stroke. Okay. So there are different tips and tricks that we have up our sleeve that we use to assess individuals' visual field. Their visual acuity, sometimes they just rhyme off. They've done the test so many times that they just do it, right? So I wouldn't say that they couldn't be assessed, but it wouldn't be necessarily as fulsome an assessment. We would try everything, so we don't want to assume that they can't do something, but there are places where we would potentially question if things don't line up well, whether or not we're capturing the dementia or the visual impairment.
Okay, thank you. We have another question from Kayla. How long would you recommend patching? Do you recommend switching patching between eyes?
For patients that have diplopia, it is until it's resolved, right? So it's we're usually not dealing with individuals that are young that we're worried with interfering with the visual system if we patch for too long. It's just a matter of symptom resolution. And typically you patch the affected eye, so the eye that's turned. And it's until it's resolved, right? And I have patients that are patched long term because that's what they prefer over prism or other options.
Okay. Okay. There's another question from Barbara Ann. I have a patient come in with blurred rather than patch lenses to help with diplopia. I had not seen that before, but the patient reported it helped.
Yeah, some people are really bothered by just losing all that light through that. So they're not able to see. Everything's very, very fuzzy and it's dense enough that it reduces that double vision, but they're still getting light through it. So it feels more comfortable. It's probably something called a bang girder foil that they're working with.
Okay, thank you. I had a request to post the link, so I have done that in the chat. It's 2:58, so thank you very much, Dr. Labreche. That was awesome. So much learning and a lot of engagement from the audience, which we really appreciate.
Excellent.
Yeah, so as people close the webinar, they will have another option to click on the link to do a very short evaluation, because we do really appreciate hearing from our audience, as this is the time of year that we're planning next year's education events. Tomorrow, everyone that registered will receive an email with a recording of the webinar and a link to Dr. Labreche's slides. And if they have any questions that come up, feel free to email me and I can forward them along. And so just the links are on the side. We have a couple more Stroke 101 webinars. The next one is Cognitive Changes After Stroke, and a new 3-webinar series called Common Approaches to Less Common Strokes. And Dr. Katsanos will be presenting on the epidemiology and pathophysiology and ICH on February 15th. And that link is also in the chat. So lots of thank yous are coming up. And we also thank you very much for taking the time to share your expertise with us.
No problem. And I welcome any questions in the future. Thank you.